a case on mass per abdomen. A 14-year-old female named Ume Kulsum, hailing from Chamrajpete, Bengaluru, who is a student studying in 9th standard, belonging to the lower socio-economic status according to modified Kupuswamy classification, was examined in the KIMS hospital on 10th April 2023. Her chief complaint was pain in the abdomen since 3 months. The patient was apparently normal 3 months back when she developed abdominal pain, which was insidious in onset, gradually progressive, and it was of dull aching type in the left lower abdomen, which did not radiate to any other part of the abdomen. It aggravated during her menstruation, and it was relieved on over-the-counter medications and when she was not menstruating. The patient complained of severe abdominal pain during her last episode of menses, which was also associated with 3 to 4 episodes of vomiting that was non-projectile, the content being food particles. She did not have any history of fever with chills. There is no history of burning or increased frequency in micturition. There is no history of urinary retention. There is no history of any vaginal discharge. No history of cough, weight loss, or loss of appetite. No history of intermenstrual bleeding. No history of heavy menstrual bleeding or irregular cycles, and no history of fatigue, palpitation, or breathlessness. Her past menstrual history: age of menarche was 12 years. She has 28 to 30 days regular cycles with 4 days of bleeding. She changes 2 to 3 pads per day with no clots and and she has dysmenorrhea. Her last menstrual period was on 23rd March 2023, and her last to last menstrual period was on 17th February 2023. Past history: there's no previous history of hospitalization, surgery, medications, or blood transfusion. She's not a known case of diabetes, hypertension, thyroid disorders, asthma, or epilepsy, and there are no known allergies or bleeding tendencies in the patient. Obstetric history: she is not married, so G0, P0, A0, L0. Family history: there is no known case of similar conditions in the family, and there's no history of any malignancies in the family. Personal history: her diet is mixed, predominantly vegetarian. Appetite is normal. Sleep is adequate. Bowel and bladder movements are regular, and habits, no addictive habits are present.
Okay. So we'll do one thing. We'll start with the history, chief complaints.
Yes, sir.
So first thing I would like to discuss what is the age of what is the importance of the age. Patient particulars. We'll start with the patient particulars slides. Yeah. What is the importance of age in mass per abdomen, particularly in a gynecological mass per abdomen?
Yes, ma'am. So certain masses or certain tumors in the female genital tract, they are more common in the reproductive years of a female, whereas some of them are more common in the perimenopausal or postmenopausal age, ma'am. This correlates with the levels of estrogen in the body. So the patient who has just entered reproductive age will have high estrogen levels, so we can rule out certain possibilities and consider certain differentials, ma'am.
Yes. Okay, so I just want to concentrate on the ovarian tumors. So with relation to ovarian tumors, so what type of ovarian tumors are common in the reproductive age group? What type of ovarian tumors are common in the extremes of age, like that?
Ma'am, germ cell tumors are common in reproductive age, whereas epithelial tumors like mucinous cystadenoma, serous cystadenoma, these are common in the extremes of age, ma'am, in elderly.
Okay, I'll just give some more tips on this. So generally, yes, epithelial ovarian tumors are the commonest type of ovarian tumor. So we have totally, as per the WHO classification, there are many types of ovarian tumor. Most common is epithelial ovarian tumors. So there can be even germ cell tumors or sex cord stromal tumors or gonadoblastomas. These are the major classification. It can be even other types also, smooth cell or lipoid cell, metastatic tumors, like that. Okay, but commonest are epithelial ovarian tumors, as we all know. Okay, so in the reproductive age group and in the menopausal women, actually epithelial ovarian tumors are the commonest. Okay, so epithelial ovarian tumors generally come in the reproductive age group. Okay, whereas germ cell tumors are common in the younger age group, particularly when the girls usually present at the teenage or in the early 20s, when they're present in the less than 25 years. When the girls usually present with the mass per abdomen being an ovarian tumor, most likely that there are 75% of them are going to be germ cell tumors. Okay, so in coming to sex card cell tumors, so here you have got actually estrogen secreting ovarian tumors and androgen secreting ovarian tumors, right? So estrogen secreting ovarian tumors are generally common in the postmenopausal age group. Okay, whereas androgen secreting ovarian tumors are usually common in the younger girls. Okay, but as such, sex card stromal cell tumors are quite rare. Okay, so generally, even younger girls present with ovarian tumors, we usually think in terms of germ cell tumors. Okay, like it could be dermoid, dysgerminoma, mature cystic teratoma. These are the common tumors in the younger girls. Okay, whereas in the reproductive age group and in the menopausal women, it is usually epithelial ovarian tumors, which are very common. So that should be kept in mind. Okay, yeah. So coming to the chief complaint. So here, yeah. So here our only complaint is only pain abdomen. She has never noticed mass per abdomen or anything. She does not have any other complaints except for pain in the abdomen and also vomiting. So these two are her chief complaints. So vomiting you presented only later, but because that is also one of the chief complaints, I think that should be mentioned here. Okay. So in coming to a history of present illness. Okay. So yeah. So coming to the history of present illness, here there is only some confusion because you have written that this pain has been relieved on when she is not menstruating. So does that mean that it is only pain during menstruation? Is it only dysmenorrhea?
Yes, ma'am, only dysmenorrhea.
Yes, good. So in that case, her chief complaint should have been pain during menstruation for the last 3 months. Okay. So pain, chief complaint should be only pain during menstruation for the last 3 months, not in general pain abdomen. Okay. So, and whenever we are describing pain during menstruation, so we have to describe what are the types of dysmenorrhea. Okay. So we know that there are usually, yes, 3 types of dysmenorrhea. One is
spasmodic,
congestive,
and membranous.
Yes, membranous dysmenorrhea, or it can be mixed type of dysmenorrhea. So here, whenever you are describing dysmenorrhea, so how do we know that it is spasmodic dysmenorrhea? How do we know that it is congestive dysmenorrhea?
Ma'am, spasmodic dysmenorrhea doesn't last more than 24 hours, ma'am, and it's commonly seen in younger girls who have just recently started menstruating, ma'am, and the pain will not be there before the onset of menstruation, ma'am. It will start when menstruation starts.
Okay, yes. So spasmodic type of pain, they're usually physiological in nature. It's quite common in the younger girls. 40 to 50% of the girls usually have spasmodic dysmenorrhea. It usually, this pain, typically what happens is it's a colicky type of pain. It's an intermittent colicky type of pain. Starts with onset of menstruation and it peaks in the first 24 hours. It never lasts more than 48 hours. So that is a typical feature of a spasmodic dysmenorrhea. They usually don't have premenstrual pain. And usually pain also doesn't last for more than 48 hours. So that is a typical feature of a spasmodic dysmenorrhea, and it is usually a physiological in nature. It's usually physiological in nature. Whereas pathological dysmenorrhea, also called as congestive dysmenorrhea, usually starts at least few days, okay, 3 to 5 days prior to the onset of menstruation. It usually peaks during the menstruation, and it may last up to 3 to 4 days during or after the menstruation also. So there is something called as triple dysmenorrhea, where the pain is there before, during, and after menstruation. So it is usually seen in which type of tumors? Triple dysmenorrhea.
I'm not sure.
Okay. Yeah. So that is usually quite common in the reproductive age group women with endometriosis. So triple dysmenorrhea generally, classically, it is usually in the women with the endometrioma. Okay. So that is also quite common in the reproductive age group women, not in the younger girls generally. Where it's very rare to have a adolescent endometriosis. Okay, so here the girl usually has actually presented with typical features of dysmenorrhea, and also she has got vomiting associated with a pain abdomen. Okay, so that is a main complaint, but she does not have pain after the menstruation is over. She does not have pain in the intermenstrual phase. Yes. Okay, yes. So coming to the next slide. Yeah. So can you tell me the importance of the negative history? Why did you take this negative history for this case?
Yes, ma'am. So, ma'am, fever of chills, I am trying to rule out the non-gynecological causes as well as pelvic inflammatory disease, ma'am, because there will be fever in PID, and fever with chills can also be there in other dengue, malaria, and also that I wanted to rule out. Ma'am, history of burning or increased frequency of micturition could be because of a urinary tract infection, which can mimic signs of lower back pain, which radiate to the abdomen. So that I wanted to rule out. Retention of urine, again, I ruled out for any pathology due to which there is compression over the urinary bladder causing pain due to heaviness. Ma'am, vaginal discharge I ruled out for any infections which cause pain during menstruation. And cough, weight loss, and loss of appetite, I mainly asked to check for malignancies and tuberculosis, ma'am. Intermenstrual bleeding is common in polyps, ma'am, which cause abnormal uterine bleeding, but it's not seen in her. But and heavy menstrual bleeding and irregular cycles are common in fibroids, ma'am, which can also present as mass per abdomen. And fatigue, palpitation, and breathlessness are secondary to blood loss due to abnormal or heavy uterine bleeding, ma'am.
Yes, you're right. Okay. So because the girl has presented with dysmenorrhea, so the first negative history should be any other associated menstrual abnormalities. So that's how the negative history start. So whenever you have got any leading history like pain abdomen, you have got definitely, as you mentioned, you have got some certain gynecological and non-gynecological condition or surgical causes for the pain abdomen, which you wanted to rule out. Yes. And the important first thing you have to write is other menstrual abnormalities, like no history of heavy menstrual blood loss, no history of any intermenstrual bleeding, no history of irregular cycles, because it can be that maybe the girl may be suffering from the endometriosis, and it could be even rarely adenomyosis, which are rare in these girls, quite common. Okay. So no history of any mass per abdomen. That also should be there in the one of the negative history. Yes, as you mentioned, we have to rule out urinary tract infection, cystitis, which is quite common even in the younger girls. Okay, so history of fever, any other micturition abnormalities are important. Pelvic inflammatory disease is usually happens most of the time only in the reproductive age group women who are sexually active. It is usually unlikely to happen in the younger girls. Chronic PID, that is due to tuberculosis, yes, it may happen at any age group. But generally, acute PID are usually in the reproductive age group women who are sexually active. Okay, yeah. So you can ask no history of any mass per abdomen also as one of your negative history. Has she noticed any mass per abdomen? And it is important whenever the girl has presented with pain abdomen other than dysmenorrhea, like in any generalized pain abdomen, it is important to rule out actually even appendicitis, cholecystitis, or even pancreatitis, any of these conditions. Okay, so that is also equally important. Yeah, okay. So coming to the next slide. Okay, so she doesn't have any other menstrual abnormalities other than the dysmenorrhea. Okay, yeah. So it's important to know the last menstrual period. Okay, generally it is important in other gynae cases, not in this case specifically. Okay, in other gynae cases, it is very important to write the last menstrual period for all the gynecological conditions, because procedure management is actually dependent on the LMP. Okay, yeah. So coming to the obstetric history. So in this girl, actually it is, she is an unmarried girl. But in general, what are the important things in the obstetric history in other ovarian tumors? What are the other important things what you want to take in the obstetric history?
Ma'am, the parity index is important because if there are multiple pregnancies, that's a protective factor in ovarian cancers, ma'am. So parity is important, and if there's any contraception which is used, OCPs are protective against ovarian cancer. So that is significant here, ma'am.
Yeah, you're right. Okay, so these are the important things to remember in the obstetric history is what are the factors which are protective regarding ovarian cancers. Okay, so why do you think they are protective? Like you mentioned, oral contraceptive pills, or it could be pregnancy, lactation. Why do you think they're protective?
So, ma'am, ovarian cancer is an estrogen-dependent cancer, ma'am. So it increases with hyperestrogenic state. So, if there is early menarche or late menopause, then estrogen exposure is more. If there are repeated pregnancies, then that reduces the risk, ma'am, because during that period, estrogen exposure is less, and OCPs also are protective against ovarian cancer, ma'am.
Yes, true. Generally, when we say endometrial cancer, we say that it is a hyperestrogenic condition. Hyperestrogenic condition leading to endometrial hyperplasia, which the basic cause is because of the ovulation. Okay, so we know that every month there is an ovulation, there is a breach in the surface epithelium of the ovary. So whenever there is a cell division happens to repair this breach, so mutations can happen, which can lead to mitosis and later malignancy. So ovulation is the one of the important risk factor. And this is the main reason even why epithelial ovarian tumors are common. Not the other type of ovarian tumors are not common. So epithelial ovarian tumors are very common because ovulation is considered to be the risk factor. Okay, so whatever condition causes an ovulation is a protective factor for a ovarian cancer. Okay, so like you mentioned, yes, main important is as a pharmacotherapy agent, it is actually oral contraceptive pills. The main mechanism of action is definitely an ovulation. So multiple pregnancies, multiparity, okay, lactation, okay, and they're all actually protective for the ovarian cancer. And risk factor, as you mentioned, actually infertility by itself. Okay, and ovulation, infertility are the any drugs which are used, or if it is any early menarche and late menopause, as you mentioned, where there is a prolonged more years of ovulation is there, that can add to the risk of ovarian cancer. Okay, so what is the benefit of oral contraceptive pills? Can you tell me what exactly, how much protection it can offer?
Ma'am, in terms of percentage, I'm not sure, ma'am, but the mechanism of action is it centrally blocks, like there's a negative feedback to GnRH, so the level of estrogen and progesterone decrease, so there'll be an ovulatory cycle.
Yes, true. Okay, so endogenous FSH and LH is completely suppressed. It causes basically an ovulation. Okay, so by giving oral contraceptive pills, for giving at least for 5 years, it actually reduces the risk of ovarian cancer by 50%. So there is 50% reduction after 5 years of use of oral contraceptive pills. And even if she stops at 5 years, the protective effect actually lasts for the next 15 years also. Okay, so that is a risk reduction which is given by the combined oral contraceptive pills. Okay, yeah, and even other methods of contraception, like even DMPA, dipomedroxyprogesterone acetate, that also causes mainly an ovulation. So that also has got some effect on the prevention of ovarian cancer, but mainly it is actually combined oral contraceptive pills. They are the ones by causing an ovulation reduce the risk of ovarian cancer by almost 50% after 5 years of use. Okay. So even in the other important thing in the contraception history, what you should remember is even sterilization. Okay, so even salpingectomy or tubectomy also reduces the risk of ovarian cancers. Okay, so any idea how it reduces the ovarian cancer risk?
No, not sure, ma'am.
Yes. Okay, so it's okay. So ovarian cancers, what usually they say that most of the epithelial ovarian tumors arise from the fimbrial end of the ovary. Okay, so by doing salpingectomy, it actually provides protection against epithelial ovarian cancers. Okay, and there are some of the ascending carcinogens which can cause ovarian cancer. So one of the ascending carcinogen is known to be actually perineal talc. So use of talcum powder. Okay, it's one of the important carcinogen. It has been identified as a carcinogen for ovarian cancer. So by doing tubectomy, simple tubectomy, the ascending carcinogen entry can be prevented to the ovary. So that can also has an effect of a risk reduction on the ovarian cancers. Okay, so it is important to mention all the parity details, how many years she has breastfed the baby, okay, and when she resumed her cycle, and what are the contraceptive methods she has used, and whether she has undergone sterilization or not. So all these are important in the obstetric history. Okay, definitely not in this case because she's been actually she's 14-year-old girl. So it is not relevant in this case, but generally if you're taking the mass per abdomen or ovarian tumor in the reproductive age group or a perimenopausal or a postmenopausal age group, then it is important to mention all the details of parity, breastfeeding, lactation when she resumed her cycle, and whether she has used any other contraceptive methods, and whether she has been sterilized or not, tubectomy has been done or not. They're all important. Okay, and it is also important to note any periods of infertility between the pregnancies, like she attempted pregnancy by taking ovulation induction. Okay, infertility by itself has actually a risk factor for a ovarian cancer. Okay, so all these are important risk factors for a ovarian tumor.
Yes, ma'am.
Okay, next slide. Yeah. So here we need not write no known case of similar conditions because she has got only dysmenorrhea. Okay, if she had come with mass per abdomen, yes, you can write history of similar condition is not there. Otherwise, it usually becomes a routine practice. We write that no history of similar conditions, but actually the condition we still don't know. We are still in the history part, right? So as per her complaints, we do not write no history of any similar conditions in the family. Okay, but it is, as you mentioned, it is very important. As you have rightly written, there is no history of any malignancies in the family. So what all malignancies are important in the family for a ovarian tumor point of view?
Yes, ma'am. So ovarian tumor is mostly associated with BRCA1 mutation, ma'am. Almost 40% BRCA1 mutations can have ovarian tumor. Other than that, BRCA2 mutations and Lynch syndrome, ma'am, HNPCC are also associated with ovarian cancers, ma'am.
Yes. So hereditary breast ovarian cancer syndrome. Okay. So one is actually hereditary breast ovarian cancer syndrome, which are associated with BRCA1 and BRCA2 mutation, what we call it as BRCA1 and BRCA2 mutation. Okay, so they're usually associated with hereditary familial breast cancer or breast and ovarian cancer syndrome. So other one is actually you have got Lynch syndrome. Okay, so Lynch syndrome is nothing but a HNPCC, hereditary non-polyposis colorectal cancer. Okay, so HNPCC is also one of the important risk factor. So all of them actually have got an autosomal dominant pattern. So if there is a malignancy in the family, it is important that you write a pedigree chart. How exactly they are affected. Like one of the person, like grandmother may be having a breast cancer, whereas mother may be having ovarian cancer. Okay, it can be two different cancers. Even the grandmother or one of the aunt may be having actually a colorectal cancer, colon cancer. Okay, so it is important to write a proper pedigree chart so that you will be able to analyze the type of malignancies and whether they are related to this the familial cancers or not. So that can be made out. Okay, so it is important to write a familial cancer pedigree chart should be written, and it usually typically follows a autosomal dominant pattern. So it is important to write. Okay, so as you mentioned, yes, BRCA1 and 2 actually have got very high risk. So just mere presence, they usually, if there is a family history of cancer, okay, so they usually test the family members. Also, the next generation family members are also tested. But if there is a BRCA1 and 2 positive, doesn't mean that they almost always they develop cancer. Okay, so the risk of ovarian tumor with BRCA1 positivity is almost approximately 40%. Okay, with BRCA2 positivity is approximately 20%. That means rest of the women may not actually develop always. But in these women, it is important to remember the chemoprophylaxis. Okay, so whenever there is a family history, these women should be ideally be treated with oral contraceptive pills as a risk reductive management. Okay, so you should be giving risk reduction management using oral contraceptive pills till they plan their family. Okay, so once they plan their family, you stop the contraceptive methods, they can plan their family, and once they complete the family, between 35 to 40 years, they have to undergo risk reducing surgeries. Okay, so risk reducing surgery means generally they have to undergo prophylactic salpingo-oophorectomy, like that. Okay, so but that will be done only at a later age. Okay, just because family history positive doesn't mean that you directly do a prophylactic salpingo-oophorectomy in the younger girls. We usually give them chemoprophylaxis, that is in terms of oral contraceptive pills. That is when it is very important. That is when it is very important in these girls. Then they can go for screening. Annual screening of this ultrasound transvaginal scan can be done. So generally there is no standard screening method for a ovarian cancer. Unlike carcinoma cervix, you have standard pap smear, right? Here you don't have a standard screening method for ovarian cancer, but here you can use actually a simple method based upon the family history. It can be done. Okay, yeah.
Personal history.
So we'll take up the doubts later, or we'll do one thing. We'll personal history. You have written everything. Importance is to give for the loss of appetite and loss of weight. Okay. So before going for the examination, we'll just finish up the doubts regarding the theory part. Whatever the doubts has been posted in the chat box. Okay. So whether chronic PID due to tuberculosis is painful or painless. So generally, chronic PID is actually relatively painless. Okay, chronic pelvic inflammatory disease is usually painless. They generally present with usually loss of appetite, loss of weight, or hypomenorrhea, reduced flow during cycles, followed by complete amenorrhea. That will be the most common presentation. But if there is a pyosalpinx, like there is a tubo-ovarian abscess or a tubo-ovarian mass, they may present with even lower abdominal pain. Okay, so generally chronic PAD is relatively painless, but it depends upon the complications how they develop. If they develop tubo-ovarian mass or a tubo-ovarian abscess, and there is a dense pelvic adhesions, yes, they may present with actually pain also. Okay, so what is the risk reduction of ovarian cancer with salpingectomy? Okay, so with salpingectomy, the risk reduction is 0.5. That is only 50% of the risk reduction is there even with salpingectomy. Okay, so as I mentioned, in the family cancers, in the familial cancers, particularly when the girls are positive for BRCA1 and 2 positive, they have undergone prophylactic salpingo-oophorectomy. So when they studied these specimens of salpingo-oophorectomy, okay, they found that most of the ovarian tumors are actually arising. 50 to 60% of the ovarian tumors are actually arising from the fimbrial end of the fallopian tube, not exactly from the surface epithelium of the ovary. Okay, so by doing complete salpingectomy, it is only 50 to 60% reduction, not 100% protection against the ovarian cancer. Okay, so they're also called as, they found that these specimens, salpingo-oophorectomy specimens, actually had serous tubal intraepithelial cancer, stick tumor. We call something called as serous tubal intraepithelial cancer. Okay, so that is actually found in these girls commonly. So they made a hypothesis that most of the ovarian cancers, almost 50 to 65% of these ovarian cancers actually arise from the fimbrial end of the fallopian tube, not from the ovary. But other 40 to 50% actually arise de novo from the ovary itself. So those are not prevented by salpingectomy. So those can be prevented only by removal of the complete ovary, which is usually done once they complete the family. Okay, so at what age chemoprophylaxis is started in the BRCA1 and 2 mutations? So generally chemoprophylaxis, it's important to stop the ovulation in these girls. Okay, so what happens is generally chemoprophylaxis is started as soon as you diagnose that it is BRCA1 and 2 positive, and once they attain menarche. Okay, so once they attain menarche and you know that they have a gene mutation, BRCA1 and 2 mutation, better to start chemoprophylaxis as early as possible, as soon as the menarche has happened. Okay, so that is the doubts in the chat box. Okay, yeah, so family history is done. Personal history, yes, everything is correct in this, and importance should be given for the actually loss of appetite and loss of weight, which is usually common in ovarian cancers. Yeah.
Summary: a 14-year-old female presented with complaints of pain abdomen during menstruation since 3 months, which was which was associated with vomiting in the most recent menstrual episode. She's unmarried and there have been no complaints in the past. Menarche was 2 years ago and the cycles are regular, associated with dysmenorrhea.
Okay.
General physical examination: she's a young female who's well built and
I just wanted to point out, she has attained menarche very recently, just 1 to 2 years. No, most of the time previous cycles can be anovulatory, and now she has started with the ovulatory cycles. Possible that it could be just physiological dysmenorrhea also. So that could be one of the things. And but anyway, as a part of the checkup, she would have got an ultrasound done, and maybe she is diagnosed as mass per abdomen and referred to the gynecological department. That also could be a possibility. Okay, so but if that thing is told by the patient, like she says that actually I had pain during menstruation, for which I went to the hospital, and then they did an ultrasound for me, and then they actually admitted me. In that case, you can mention that in the history of present illness, like patient went with these complaints to the local hospital, or she presented to the OPD with these complaints, and she underwent ultrasound, and later she was admitted, telling her that she has some mass in the abdomen. So that also can be included in your HOPI.
Yes.
Okay. Yeah.
Her pulse rate is 92 beats per minute, ma'am. It's normal. Blood pressure is 136 over 80 mm, which is measured in the right arm in supine position. Respiratory rate and temperature are normal, ma'am, like afebrile. She has pallor present, but there is no icterus, clubbing, cyanosis, lymphadenopathy, or edema. Her height is 172 centimeters and weight is 84 kg, and the BMI is slightly high, ma'am, 28.39 kg per centimeter square. Breast examination: the both breasts are appearing normal. Thyroid appears central and normal. The spine also appears normal, ma'am.
Yes. Okay. So in the general physical examination, so importance should be given actually for the features of anemia and BMI, as you mentioned. Yes, obesity is usually very common in endometrial cancer. So status of hyperestrogenic condition, obesity, they usually go in favor of endometrial cancer. Generally, ovarian cancers are usually thin built. But anyway, this girl has been basically obese. Okay. And importance should be given actually for the edema. Okay, and lymphadenopathy. This. Okay, edema. We know that it can ovarian tumor. In ovarian tumor, girls can present with edema, both unilateral and bilateral. What is the reason why there is edema? Pedal edema.
Ma'am, if the mass is too large, then it may compress on the inferior vena cava in the structure, so that can cause venous pooling and edema.
Yes, so it could be venous stasis edema, or it could be even lymphatic edema. Advanced ovarian cancers usually can infiltrate the lymphatics, which can lead to even lymphatic edema. So it need not be bilateral pedal edema always. It can be even unilateral pedal edema in these cases. That also should be kept in mind. Okay, lymphadenopathy. Yes, for ovarian tumors, actually the lymphatics is mainly actually pelvic and the para-aortic lymph nodes, which are not felt by your examination. So generally, what you are going to feel is only supraclavicular and usually the inguinal lymph nodes. Okay, but if they are palpable, what does it mean?
That means it is metastasized, ma'am. It's a higher grade.
It's advanced or a stage 4 ovarian tumor. It's a very advanced ovarian tumor. If it's already supraclavicular lymph node and the inguinal lymph nodes are already felt, that means it is an advanced ovarian cancer. Okay, yeah. So, and the importance is actually should be given for the breast examination. So there can be concurrent breast tumor along with the ovarian tumor also. So that is the one important thing which should be kept in mind. Okay, and it is also important in the familial cancer syndromes that you are going to screen for any abnormality in the breast, and you can offer them screening with a mammogram if required. Okay, yeah. So that is about general physical examination.
Ma'am, I wanted to point out that since the patient was already obese, she didn't pay much attention to the distension of the stomach. That's why I didn't make it the chief complaint of mass per abdomen. She mainly came for the pain.
Yes, yes, possible. Most of the time, they wouldn't have noticed that there is a distension of the abdomen or the mass abdomen. They wouldn't have noticed because of the abdominal obesity. Yes.
Ma'am, systemic examination is normal, ma'am. CVS, RS, and CNS.
Yes. Yeah. So here one important thing which should be kept in systemic examination important is actually examination of respiratory sounds. Sometimes it is possible that you may have a reduced breath sounds in the infrascapular areas. It could be due to pleural effusion. Okay, it not in these girls generally. Yes, in the postmenopausal women presenting as a ovarian tumor, or sometimes it could be benign ovarian tumor with ascites and pleural effusion. So that is, yes, good. So Meek syndrome is, tell me what about Meek syndrome.
Ma'am, an ovarian tumor, usually the germ cell tumor, ma'am, along with ascites and hydrothorax causing pleural effusion, ma'am.
Yeah. And so Meek syndrome is actually ovarian fibroma. It's a benign tumor. It's a ovarian fibroma with ascites and the right-sided hydrothorax or the right-sided pleural effusion is called as Meek syndrome. So pseudomix is any other tumor, any other ovarian tumor associated with the same ascites and the right-sided hydrothorax is called as pseudomix. Okay, so yes, so this is a Meek syndrome. So it should be kept in mind that when you're doing the auscultation, whether any, particularly if you have a postmenopausal woman with a large ovarian tumor, she has ascites and all that, they usually ask whether there was a pleural effusion also or not. So clinically, have you examined respiratory system? So that should be kept in mind when you're examining a postmenopausal woman with ascites. Okay, yeah.
Per abdomen examination, inspectory findings, the abdomen is distended. All quadrants move equally with respiration. The umbilicus is central and inverted. There are no dilated veins, scars, or sinuses. The hernial orifices are intact. There are no visible pulsations, and a visible lump is present in the suprapubic and left iliac fossa.
Yeah, finish of the examination, we'll go back.
Palpatory findings, there's a single cystic mass which is 10 into 8 centimeters noted in the suprapubic region extending up to the left iliac fossa. Borders, the upper border is felt in the midline, which corresponds to a uterus of 20 weeks size, and the side borders are felt around 8 centimeters from the midline in the left iliac fossa. There is no local rise in temperature. There is no tenderness. The shape of the mass appears globular. The surface is smooth and the skin over the mass is normal. The consistency of the mass is variable, ma'am, like some areas cystic and some areas firm. It is non-fluctuant and there is limited mobility, which is from side to side. No organomegaly was felt and there is no evidence of free fluid in the abdomen. On percussion, a dull note was felt over the mass and there was no shifting dullness present. Bowel sounds are heard on auscultation and bimanual examination was not done.
Okay, so we'll go back to abdominal examination. Okay, yeah. So here on inspection, so first thing you comment is actually any positive findings are there. So here you mentioned that, I mean, she has abdominal obesity, but there's a visible lump in the area, whatever you have mentioned. No? So that should be the first thing. Okay, so whether there is a visible lump in the, so best thing would have been actually, you should mention that, just a minute, instead of writing suprapubic area, so you know that abdomen is divided into standard quadrants, right? So that it should be written as hypogastric area. So, so for supra, we usually when we're telling scars and all, we write suprapubic transverse scar. But when you're telling the mass per abdomen, when you're giving whether it's in the surgery or in the OBG, mass per abdomen should be told in terms of quadrants. Okay, I'm happy that you have included all the points in the mass in the next slide actually. So first thing here in the inspection, so you mentioned is if the mass is seen, what are the areas approximately? So it is in the hypogastric area and left iliac fossa. So you can make out there is a visible lump in the hypogastric area and in the left iliac fossa. But it is possible that in the inspection, most of the time you may not be able to make out anything, particularly if there is a abdominal obesity. Only in the palpation you may be able to make out. So you can comment only in the palpation also. It is not compulsory that you have to comment on the mass per abdomen in the inspection. If it is not too obvious, if it is not very obviously made out that lower abdomen distension is not there, you need not comment. Okay, so then you can mention all the other points. Okay, that abdominal obesity is present and umbilicus is central and umbilicus is central and no dilated veins, scar sinuses, all the quadrants move equally with respiration, hernial orifices are normal. So that can be written. Okay, in the palpation. Coming to the palpation, yes. So in the palpation, generally, whenever we are describing the mass per abdomen, there are 7 important things what we are going to write. So first thing is actually a site or the location. Okay, site, size, and the shape. Okay, site, size, shape. These are the 3 important things what you are going to write. Then you are going to write on the surface. Okay, then is the margins or borders. Okay, you can call it as borders. For deeper tumors, we usually say borders, not the margins. Okay, borders. Okay, then we comment upon the consistency. Okay, then we comment upon the mobility. Okay, so these are the 7 things which always should be written, whether it is a mass per abdomen in the surgery case or the mass per abdomen in the OBG case. Okay, in the gynecological masses. Okay, yeah. So here you have written actually location of the mass you have written. So again, here I want to point out that don't write the suprapubic area, write the quadrants of the abdomen. Okay, and whenever you're writing the mass, okay, so whatever quadrant it is occupying completely, okay, that should be written first, then extending into these areas. Okay, so like mass is occupying the hypogastric area and left iliac fossa, extending into umbilical area and the left lumbar area. So I assume because it is 10 centimeter mass from the suprapubic, I think it is extending into the umbilical area. Okay, so you can say mass is felt in the hypogastric area and left iliac fossa, extending into umbilical area. Like it is not completely occupying the umbilical area, but some part of the umbilical area has got this mass. Okay, so you have to write the quadrants clearly. That is very important. And you have written the measurement. Yes, good. So though it is an abdominopelvic mass, the measurements are not accurate because some part of it is actually in the pelvis. Okay, but still whatever mass is felt on palpation, because you're writing the palpation finding. So whatever is mass is felt per abdomen should be written. The measurement should always be written. It is correct. Okay, so though it is abdominopelvic mass, you have to write the size of the mass should be written. Okay, and it is difficult to comment on the shape of the mass for gynecological masses. Like it not the whole thing may not be palpable to say it is globular. Okay, for surgical masses, yes, you can say generally, but generally for gynecological masses, we don't comment upon the shape of the mass. Okay, so it's globular mass or longitudinal mass. We usually don't comment because they're not completely felt per abdomen. They're usually arising from the pelvis. So usually shape of the mass cannot be commented generally. But if it is a long pedunculated ovarian tumor, which is completely felt in the abdomen, they have a long pedicle or long pedunculated subserous fibroid, they're completely felt in the abdomen. Yes, you can write they're globular. Okay, so generally avoid talking about the shape of the mass. Okay, in gynecological masses, it is not required. Okay, and you have written surface is smooth. Yes, it's very important to mention whether the surface is smooth or lobulated surface. It's an irregular surface. It is important to mention. Okay, then you have mentioned, yeah, next slide. Consistency. Yes, it's very important to mention the consistency. And non-fluctuant generally means for the superficial masses. Okay, like superficial masses over the skin, or in the superficial masses are the lipoma, like that. No, there we write actually abscess, like that. We usually mention fluctuant swelling, non-fluctuant swelling. Usually for the deep visceral masses, we usually say mobility. Okay, so if you have mentioned mobility and fluctuation, both you have written. So if you write mobility, that is more than enough. So whether horizontal mobility is present or not, or whether the mobility is present from side to side or in the vertical direction, yes, that should be written. And when you're writing, then you have to write no other organomegaly. You have already mentioned the one organomegaly, so you have to write no other organomegaly, like no hepatomegaly, no splenomegaly. That's what if you mean by that. Okay, so you have to write no other organomegaly. Okay, and here no evidence of free fluid. Actually, you should write it in the percussion. You have written there, but again you have written in the palpation also.
Okay.
Okay, yeah.
Yeah.
Then in the percussion, yes, you have written dull note, and yes, yeah, all this is perfect. So bimanual examination, usually it is not done also. We usually don't do the bimanual examination in the undergraduate examination, so it is not required for you. Okay. So can you tell me how do you differentiate uterine masses from the adnexal masses by clinical examination?
Yes, ma'am. So, ma'am, in uterine masses inspection, ma'am, we can it's not very different from adnexal.
In general, palpation, you tell me. It's okay.
Okay, fine, ma'am. In palpation, ma'am, we feel for the consistency, ma'am. Uterine masses are usually firm, whereas ovarian masses can be variable. It can be cystic. It can be firm also. Then, ma'am, we look for in the borders, ma'am. If it's a uterine mass or a pelvic mass, then the lower border will not be felt, as it's usually originating in the pelvis, so that we can make out, ma'am. Then the surface, ma'am, we can it could either be smooth or irregular. In fibroids, ma'am, it can be irregular surface. And ma'am, like I said, consistency, ma'am. Mobility, if it's a pedunculated mass, then it can have side to side and sometimes vertical, but mostly it has side to side mobility, ma'am. And ascites is more consistent with ovarian tumors. It's not seen in fibroids and uterine tumors, ma'am. And percussion, ma'am, over the fibroid, dull note is felt, but when we do percussion, it gives an important clue about the ascites which is present in the ovarian tumor, ma'am. If in the ascites the bowel loops are floating in the ascitic fluid, then we will find central resonant note, ma'am. But if it's pushed to the side, then we'll find peripheral resonant notes, ma'am. And ma'am, bowel sounds is the same, ma'am. In bimanual examination, ma'am, since in an fibroid or uterine mass, it is arising from the uterus, so there will not be space between the mass and the uterus, so that groove sign will not be present, whereas it will be present in an ovarian mass. And the mobility of the cervix, ma'am, in an ovarian mass, when the mass is moved, the mobility is appreciated in the cervix, whereas in adnexal masses and ovarian masses, it is not appreciated, ma'am.
Okay, so let me again, you have most of the points you have told correct. Okay, so coming to the location of the mass. So in the exams, these are the commonly asked questions. Okay, so how exactly you differentiate uterine tumors from the ovarian tumors? Okay, or if there is ovarian tumor, they usually ask how exactly you differentiate benign ovarian tumor from a malignant ovarian tumor. So these are the common questions you get. Okay, so whenever they ask the questions, so always start with the age. Okay, like age at which common, and complaints like menstrual disturbances go in favor of actually uterine tumor, not that adnexal tumor, like that. Okay, so all this should be mentioned, but here I asked you specifically regarding examination, how do we differentiate? Okay, so uterine tumors are actually midline. So coming to the first thing, location, they're usually midline. Uterine tumors are generally midline. Okay, whereas adnexal tumors are generally lateral. Okay, but you have an exception for all the rules. Okay, like if it's a broad ligament fibroid, it can be lateral, though it is arising from the uterus, right? So it can happen. So sometimes there can be a large ovarian tumor. Because of the largeness, it is actually in the center part of the abdomen. It's not always in the lateral. Okay, because of the large ovarian tumors, because of the largity, I mean the bigger shape of the size itself, they can be central in nature. But generally, if there is a central mass, it goes in favor of a uterine mass. If the lateral masses are present, they go in favor of an adnexal tumors. Okay, and uterine tumors like fibroids are usually firm to hard in consistency. they're generally firm to hard in consistency. Okay. Whereas ovarian tumors, like benign ovarian tumors are usually tense cystic. They're usually cystic, whereas malignant ovarian tumors may have variable consistency. Like sometimes there can be solid components, some areas it can be cystic, like you mentioned in this case. So it can be variable in consistency. Few areas it can be solid, few areas it can be cystic. Very rarely they can be completely hard. Like it's a complete malignant tumor, solid ovarian tumors, purely solid ovarian tumors may be present. Okay, so that is about the consistency. Okay, coming to the surface, if it's a multiple fibroid, it is going to be a irregular surface. But generally, benign ovarian tumors are actually smooth surface. They're unilocular cyst. Benign ovarian tumors are actually in general usually unilocular. Okay, whereas malignant ovarian tumors, again, they can also have a irregular surface. Okay, so benign ovarian tumors can usually have a smooth unilocular surface, but in malignancy, it can be even a irregular surface can be there. Okay, lower border is not made out in all the pelvic masses most of the time. Yes, and as you mentioned, if they have a long pedicle, they're shifted out of the pelvis. They make then lower border may be felt. So generally, when we are writing the gynecological masses, we write that all the borders are very well made out except the lower border. Okay, so that means it is a mass arising from the pelvis. That's what it means. Okay, but an exception can be there. There is a long pedicle ovarian tumor where the ovarian tumor is lifted out of the pelvis, then you will be able to make out all the borders. But generally for the gynecological masses or the pelvic masses, lower border is not made out. That is how you say that they're actually your abdominal pelvic mass. Okay. So coming to the mobility of the masses, uterine tumors are usually mobile in the horizontal direction, and most of the ovarian tumors are also mobile in the horizontal direction. If they have a long pedicle and lifted out of the pelvis, they can be even vertical mobility. Okay, but very free vertical mobility is actually one of the differential diagnosis for mesenteric cyst versus ovarian tumor. Okay, mesenteric cyst is the one which is easily freely mobile in the vertical direction, or it is mobile in the perpendicular to its axis of attachment. So the free mobility in the vertical direction actually goes in favor of a mesenteric cyst. Okay, and usually pelvic masses are horizontally mobile or from the side to side. Okay, so that is important thing. And only if there is a large ovarian tumor lifted out of the pelvis, you will be able to make out movement in all the direction, both horizontal and the vertical mobility. But they are not very freely mobile even in the vertical direction. Okay, vertical mobility, free vertical mobility actually goes in favor of a mesenteric cyst. Okay, so that is the one thing which should be kept in mind. And as you mentioned in the bimanual pelvic examination, groove sign should be kept in mind. So groove sign is when there is a adnexal, there is a tumor separately from the uterus. Adnexal tumor is there, then you have a groove. Groove is separately felt between the uterus and the mass. Groove sign is present. Okay. And the movements of the mass, when you are moving the abdominal mass, you are able to feel the movements to the cervix. Movements are transmitted to the cervix. Okay. So transmitted movements of the cervix are present in the uterine tumor. Okay. Whereas in the adnexal tumor, you have a separate groove sign and the movements of this mass is not transmitted to the cervix. Okay. So again, as I mentioned, there are always exceptions for this rule. So there is a broad ligament fibroid arising from the uterus. Okay, you may have a groove sign. Okay, and you have a malignant ovarian tumor which is attached. It's the whole pelvis. It is metastatized to the whole of the pelvis. It is attached even to the uterus. If you move that mass, the movements may be transmitted to the cervix. So in advanced ovarian cancer, it is possible because everything moves as a mass. Uterus is also stuck to the mass during advanced malignancy. But generally in the early conditions, these are the features: groove sign and transmitted mobility to the cervix are the two important things which differentiate uterine mass from the adnexal mass. Okay, yes, you are right. Okay, so we'll go to the next thing. Yeah. So again, benign and malignant ovarian tumor. How do you differentiate benign and malignant ovarian tumor? Starting from the age.
Yes, ma'am. So benign tumors are usually seen in reproductive age, younger age, and malignant tumors are seen in the perimenopausal or menopausal ages, ma'am. Benign tumors is usually unilateral, whereas malignant tumors is bilateral, ma'am. Benign tumors are unilocular and they have smooth surface, whereas malignant tumors have septations and they are multilocular. Benign tumors don't appear vascular on Doppler, whereas malignant tumors have high vascularities, and ascites is present in malignant tumors more than benign tumors, ma'am. That's
yes. Yeah. Okay. So age, as you mentioned, yes, benign ovarian tumors are usually common in the reproductive age group. Malignant are common in the extremes of age group. Okay, usually the peak age is usually between 55 to 65 years. That is when usually most of the ovarian cancers usually come up. And coming to symptom complex also, rapidity of the symptoms. Okay, patient has got rapid onset of sudden increase in the abdominal distension. Okay, sudden increase in the mass per abdomen. Yes. So the rapidity of onset of symptoms, loss of appetite, loss of weight, they all go in favor of a malignancy. Okay, so usually ovarian tumors have got vague symptom complexes. They don't present generally as mass per abdomen. They are usually present with vague gastrointestinal symptoms. Okay, they are usually present with bloating, early satiety, vomiting, GERD symptoms, recurrent gastritis. These are the symptoms are usually common. Okay, so but these symptoms have got rapid onset, like new onset GERD symptoms for more than 12 days in a month. You should always evaluate them for a ovarian tumor, particularly in the postmenopausal age group. Okay, so that is the one thing. So rapidity of onset of symptoms, loss of appetite and loss of weight, that should be kept in mind. And in the family history, is there a family history of cancer? Then you always suspect that maybe it is possible that this lady has got a malignant group. Okay, so coming to the examination part, again, yes, there usually BMI will be lesser in these women, and there may be features of pseudo-mixed syndrome. Okay, and there can be lymphadenopathy and pedal edema, large ovarian tumors, particularly in malignancy. Okay, and on examination, as you mentioned, it is benign ovarian tumors are usually smooth surface unilocular cyst. Okay, whereas here it is usually multilocular, and the consistency is the one important criteria. Here they are usually in benign ovarian tumors, there is cystic in consistency, whereas in malignancy they are usually firm to hard. Hard, or it's possible that they can have variable consistency, but they are not uniformly cystic. They're never uniformly cystic. They may have certain areas, they may have solid component, certain areas it may be a cystic component. And restricted mobility. The mobility is not very good in malignant. In malignant ovarian tumor, because of the advanced disease, they may have metastasis to the other areas. There can be omental caking, there may be a metastasis to the other abdominal organs. So and it's a fixed mass. The mass may be fixed to the uterus. So mobility is not very easy. It's a restricted mobility in the malignant ovarian tumor. Okay, and in the ultrasound. So in the ultrasound, like you mentioned, it can be unilocular, size more than, multilocularity, presence of solid components, papillary growths, okay, ascites, omental deposits, metastasis. Okay, all these go in favor of a malignancy. Okay, so whenever you ask about how do you differentiate benign and the malignant ovarian tumor, or if they ask you how do you differentiate a uterine tumor from an adnexal tumor, start from the age, complaints. If you want, you can include even the family history or obstetric history if it is relevant in that case. Like if there is a history of infertility followed by conceiving, or she had history of myomectomy, definitely this is possible that it is a uterine mass now. Okay, so if that is relevant, you can include that also. Then take the examination findings. Also tell about the ultrasound findings. Okay, how do you differentiate these tumors? So that is how it is important. Okay, yeah. So yeah, you can tell about the summary.
Yes, ma'am. So a 14-year-old obese female of
Shambhavi, one more minute. Yeah, you mentioned about the how differentiation between the ascites and the benign ovarian tumor. So sometimes what happens, there can be a large unilocular cyst, thin-walled cyst, serous cystadenoma, benign serous cystadenoma, a large tumor with fluid filled completely, benign serous cystadenoma, and that may be difficult to differentiate between the ascites. Okay, patient may be having a tense ascites also. That may also look like a ovarian tumor. Okay, that is when your percussion comes into picture. Like you mentioned, generally, it is dull note in the center. Okay, like the mass, when the ovarian mass is originating, when the ovarian mass is getting enlarged, it pushes the bowel to the sides. Okay, so on percussion, there is dullness in the center, but resonance is heard in the flanks. Okay, but if there is ascites, bowel will be floating in the fluid, so there will be resonance in the center. Okay, whereas there can be shifting dullness can be present. Okay, yeah, you mentioned that point when you told about the percussion. I just wanted to repeat it once more for the audience purpose. Okay, so percussion is very important. One is to know the ascites, presence of ascites in case of any malignancy. Like there is an ovarian tumor with ascites also. It's possible, but that time you have a firm to hard mass, which is clearly distinguished between the mass and the ascites. Shifting dullness is clearly present, but sometimes it can happen that there is a large single mass, tense cystic. So you're not sure whether it's a tense cystic ovarian tumor, benign ovarian tumor, or whether it is a ascites, tense ascites. In these things, definitely your percussion will be helpful as a part of the clinical examination. Yes, definitely you're going to confirm that with the ultrasound later. But this is one of the examination point which can differentiate ascites and a simple large benign ovarian tumor. With tense ascites can be differentiated using percussion. Okay.
Yes. Ma'am, summary, a 14-year-old obese female of G0, P0, L0, A0 presents with complaints of pain abdomen during menstruation since 3 months. On examination, she has a 10 by 8 centimeter mass in the hypogastric region, which is extending to the left iliac fossa and umbilicus. It is non-tender, variable in consistency, and there is no shifting dullness which is present.
Okay, yes. Okay. Yeah. So if I mean it's a 14-year-old girl, so you need not mention the obstetric index here, gravida 0, para 0. We need not comment. Only as a part of obstetric history, if you write unmarried, that is enough. Okay. So we need not comment upon gravida 0 and all that. If they're paras, yes, we can definitely write that. Okay. So before moving on to the management, let us answer the chats which is in relation to the examination. Okay. So how benign? Just a minute about that. Anything? Yeah, how benign fibroma, it is cause ascites. Okay, so right-sided hydrothorax can be present in any ascites as it is due to fluid moved to the peritoneal cavity, from peritoneal to the pleural cavity. Yes. Okay. So benign ovarian fibroma, it is mainly because of it's a solid ovarian tumor. Though it is a benign in nature, because of the peritoneal irritation. Okay, it causes actually ascites, and any ascites, as you mentioned, any ascites can have right-sided hydrothorax because of the transmission through the diaphragm. Okay, it can happen. Yes, but if it's a benign ovarian tumor, this is the first time it was described by Professor Meek. He was the one who described the presence of ascites and the right-sided pleural effusion, though it is a benign ovarian tumor. So that is why it is named after him. So any other condition with any other ovarian tumor, including malignant ovarian tumor, if there is ascites and hydrothorax, it will be called a pseudomix. It is only, it doesn't have any management relevance. It is only for the exam purpose only. So it was described first time as a ovarian fibroma with ascites and pleural effusion by Meek. Okay. So uterine fibroid can be vertically mobile as the whole uterus may involve. Okay. So uterus has got, uterus is never vertically mobile. Okay, uterine masses can be horizontally moved in one direction, but uterus as such itself can never be moved in the single vertical direction. No, it is not vertically mobile. Okay, whether it is enlarged or even in the normal size also, it is never mobile in the vertical direction. Okay, should local rise of temperature be mentioned in this case? Okay, yes, generally surgical cases, you always mention the tenderness, temperature, then followed by other characteristics of the masses. Okay. But here we usually don't always write rise of temperature first in gynecological masses. Okay, because we are not suspecting an inflammatory mass. So if you are suspecting a tubo-ovarian mass or appendicular mass, it is important that you always mention the local rise of temperature first, then followed by other characteristics of the mass. But generally in gynecological masses, acute inflammatory masses are quite rare. In surgical cases, yes, you can mention temperature, tenderness first, followed by other characteristics of the masses. I hope that's clear.
Yes.
Ma'am?
Yeah.
Ma'am, after delivery, ma'am, the uterus will be contracted, no, ma'am?
Yes.
At that time, we may feel the vertical, means a bit like mobile, no, ma'am. So I asked it like that.
Okay, no, uterus will never be mobile in the vertical direction. Even after delivery, even if it's the postpartum uterus, okay, I mean, maybe you are moving the uterus and you're seeing the transmitted mobility at the level of the cervix. Okay, but it is not a vertical mobility. I mean, here we are talking in terms of free mobility, mass which is freely mobile in the vertical direction and the horizontal direction. Uterine masses as such are never, or even the uterus by itself is never mobile in the vertical direction. Okay, it is freely mobile because of your hand manipulation, or the removal of the placenta and all that. That time you'll be able to make out that uterus is little softer initially and then it is becoming firm and all that, but it is not freely mobile in the vertical direction. Okay, here we are talking in terms of masses which are freely mobile in the vertical direction. Okay, uterine fibroids are usually never freely mobile.
Okay. Thank you.
Yeah. So coming to the next part.
Should I proceed?
Yes.
Yeah, ma'am, differential diagnosis. It could be a case of ovarian cyst, most likely left-sided. It could be a case of uterine fibroid, pyometra, and hematometra, but ovarian cyst is the most probable diagnosis.
Yes. So ovarian cyst, here what happened is your consistency, you told it is a variable consistency.
Yes.
So if it is uniformly cystic, you can say it is a ovarian cyst.
Okay.
It's ovarian cyst. Like she is 14-year-old girl with mass per abdomen, probably ovarian cyst. So because here you had mixed features of variable consistency, it was not typically uniformly cystic all along. So you can say it is a 14-year-old girl with mass per abdomen, probably benign ovarian tumor.
Okay.
So you are not sure. It could be mature teratoma. It can still be dermoid. It can have some areas, there can be solid areas, some areas it can be cystic. So you can say it is a benign ovarian tumor. So you mentioned that 14-year-old girl presenting with abdominopelvic mass, because you didn't make out the lower border here. Okay, so it's abdominopelvic mass. Okay, probably benign ovarian tumor because she doesn't have any other features of malignancy. So you say it is probably benign ovarian tumor. If it was uniformly cystic in your examination, yes, you can say that 14-year-old girl with abdominopelvic mass, probably a ovarian cyst.
Yes, ma'am.
Okay, so that should be your diagnosis. Okay, other differential diagnosis, as you aptly mentioned, it is fibroid. Pyometra, hematometra are common in the postmenopausal age group. Okay, very rarely it can happen in young girls. There can be unicornuate uterus with rudimentary horn with hematometra. That's a very rare diagnosis. Okay, yes, but it is still possible in the younger girls. Rudimentary horn with a non-communicating rudimentary horn. Okay, unicornuate uterus with non-communicating rudimentary horn with hematometra on that side. Okay, so that is one of the possibility. That time also they usually have unilateral dysmenorrhea. They have pain only on the one side. Like in this case, you mentioned patient had dysmenorrhea, but it was more on the left iliac fossa.
Yes.
So it is still possible, but the consistency features are usually not in favor of hematometra.
Yes, ma'am.
So here you mentioned variable consistency, mobility, and all that. So all of them don't go in favor of hematometra. So pyometra is unlikely in this case. Usually they're common in the postmenopausal women, with women with atrophic endometritis, leading to pyometra, hematometra later, or it could be CA endometrium, okay, or CA cervix. In these women, they may present with pyometra with mass per abdomen. Okay, not in this 14-year-old girl. That is unlikely. Okay, yeah.
Yes. Management. Investigation. I would like to do a complete blood count. The sugar test, ma'am, random blood sugar, urine routine, and microscopy. Transvaginal ultrasonography with color flow Doppler, and a CT scan to look for presence of any other adnexal masses, calcification or teeth, and serum markers for various ovarian tumors, including CA125, LDH, beta HCG, alpha fetoprotein, etc.
Okay, yes. So you mentioned only general investigations as a part of preoperative workup. So you need not write everything in detail because general investigations include many things. Okay, it could be even thyroid profile, chest X-ray, ECG, all those things may be required as a part of preoperative workup. So we usually write only specific investigations to confirm your diagnosis. Okay, yes, so because mass is felt per abdomen, so can you do transvaginal ultrasound? She's an unmarried girl, right?
Yes, ma'am.
Yes. Generally, you may do both, and whenever you're writing ultrasound, write it as only ultrasound abdomen and pelvis. So when there's as a undergraduate student, if you write only ultrasound abdomen and pelvis, that is enough. If they specifically ask you whether you want to do transabdominal or whether you want to do transvaginal ultrasound, so you should be able to make out what all things are made out in the transabdominal, what all things are made out better with the transvaginal ultrasound. So otherwise, don't specifically write transvaginal ultrasound. Okay, yes, we do TVS for adnexal masses, which helps better characteristics. I mean, we can better make out the characteristics of the tumor. Okay, but here it is not possible in this girl. Okay, because she's an unmarried girl, definitely will not do a transvaginal scan for her. Okay, generally they are complementary for each other. So we do transabdominal ultrasound and transvaginal ultrasound. Both we are doing. Generally, we do it for an adnexal masses. We do that. Okay, transabdominal is like a panoramic view. You get whole wide picture. You can make out the whole of the mass. Measurements you will be able to make out. You can also make out other abdominal organs, any lymph nodes, any omental deposits, omental caking, okay, uterus, everything can be made out. It's a whole wider picture, panoramic view. Whereas transvaginal ultrasound is like more like a zoom in view. It's like it's very important to make out the characteristics of the masses. Okay, like whether the mass has got a solid component, whether there are any papillary projections are there in the tumor. And to know the septal thickness, whether the septa are very thick, which go in favor of malignancy. Okay, so characteristics of the tumor are better made out with the transvaginal ultrasound. Okay, so we never do only one. We never do only transabdominal. We never do only transvaginal. They're usually complementary for each other. Okay, but based upon the age group and the sexually active status, we may or may not do transvaginal ultrasound. Okay, so here 14-year-old girl, definitely there is no option of transvaginal. Here we are going to do only transabdominal, only ultrasound, abdomen and pelvis. With a full bladder, it will be done. And you will be able to make out most of the characteristics can be made out even with an abdominal ultrasound. Okay, yes. Septal thickness, wall thickness, solid components, papillary excrusions, they're all better made out with the transvaginal ultrasound. But here it is not a possibility. Okay, so have you heard of, and you have mentioned the serum CA-125, which is the important tumor marker. Okay, why it is done? This any other tumor marker? Why serum CA-125?
Ma'am, it is a most common tumor marker which is elevated in epithelial ovarian tumors, ma'am. Others tumor markers include, ma'am, CA19-9, then alpha fetoprotein, ma'am, beta HCG, LDH.
Yes, you're right. Okay, here because she's a young girl, and the consistency is also not the smooth cystic. Here we are suspecting actually a germ cell tumor.
Okay.
Right. So for her, actually, the most important tumor marker is going to be, actually, you can do, what are the tumor marker for dysgerminoma or the teratomas?
LDH is
very good. Okay, so LDH should be done for her. LDH and the alkaline phosphatase should be done for her. Okay, yes. And if it's a yolk sac tumor, if you're suspecting a yolk sac tumor, you may do alpha fetoprotein.
Yes, ma'am.
Okay, yeah. So based upon what is your suspicion, you can do. Or as a screening measure you are doing, like you are not sure what type of tumor it is. In that case, you can do CA-125, you can do even beta HCG, you can do alpha fetoprotein and LDH. So all the 4 markers may be done. Okay, but here the most probable diagnosis in your case is actually a germ cell tumor. For her, it is most apt to do a LDH, or you may do even beta HCG and the alpha fetoprotein. So those 3 can be done. Okay, so yes, so these 3 tumor markers, LDH, beta HCG, and alpha fetoprotein are actually for the germ cell tumors. CA-125, as you mentioned, it is for the epithelial ovarian tumors, and it is a non-specific marker, right? It is not. It is not only elevated in ovarian tumors; it can be elevated in many other conditions. Okay, so is it elevated in all the in all the epithelial ovarian cancers? Any specific type of epithelial tumor where it is not elevated? It may not be elevated.
I'm not sure, ma'am.
Okay. So you know what are the types of epithelial ovarian tumors?
Yes, ma'am. Mucinous cystadenoma, serous cystadenoma, then endometrioid type, ma'am, then Brenner's tumor, ma'am.
Very good. Okay. Yes. Ovarian fibroma, endometrioid, serous and mucinous. Okay. In mucinous ovarian tumors, it may not be elevated. Okay. For mucinous ovarian tumor, the tumor marker, the preferable tumor marker is actually CA19, CA19.9, or it can be CEA, carcinoembryonic antigen.
Yes, ma'am.
CA-125 may not be always be elevated in the mucinous cystadenomas. In those women, you may have to do actually, if you're suspecting multiloculated cyst, mucinous cystadenoma, in those women, you may have to do CA19-9 or the CEA, CEA can be done. But remember, all these tumor markers, CA-125, okay, CA19, CEA, they're actually non-specific markers. They can be elevated in, there are many, even benign conditions, benign gynecological, benign even surgical conditions also, it may be elevated. Okay, so there's one more specific marker for early epithelial ovarian cancers, that is called as HE4, human epidermal factor 4. Okay, so HE4 is one of the specific marker for the epithelial ovarian tumors, particularly in the early cancers, it will be elevated. Okay, so in your case, actually, screening for germ cell tumor markers are more important. Yes, you can do even CA-125 also, but CA-125 alone is not sufficient in this case. You have to do even LDH, beta HCG, and even alpha fetoprotein needs to be done. Or if you have done a transvaginal ultrasound, if you have done an ultrasound already, you know that it is a dermoid, you can do only LDH. Yes, like already there are features of dermoid. Okay, you may do only LDH only can be done based upon your findings in the ultrasound. It can be done. Okay. So you have heard of risk malignancy indexing, RMI?
Yes, ma'am.
Yes. Can you give me some information on RMI?
I'm not sure, but ma'am, we do a panel of tests before we go for the surgery, ma'am, to classify and grade the tumor before we subject it for ma'am frozen section. We basically we do the risk assessment and
yes. Yeah. So risk of malignancy indexing is actually based upon your CA125 level and what are the ultrasound features and the menopausal status. So if you multiply these three, actual CA125 marker, what is the actual CA125 levels? Okay. And what are the ultrasound characteristics? Okay. Multiplied by your menopausal status. So that will give you the score. Okay. For ultrasound, you have got actually important 5 features. Okay. So one is actually presence of solid component and multiloculations. Multilocularity and the solid components. Okay. Third point is actually bilaterality. If the tumors are bilateral, they go in favor of malignancy. Okay. Presence of ascites and presence of any metastasis or mental cakes in the ultrasound. So these 5 features in the ultrasound are given a scoring. Okay. So you have solid components, multilocularity, bilaterality, and then you have got metastasis and ascites. So there are 5 ultrasound points. Presence of one finding is given a score of 1. If there are 2 or more points, the score will be actually a 3. Score is going to be 3. Okay. So that number should be put in your formula, RMI formula. For menopausal status, for premenopausal status, you are going to give a score of 1. For postmenopausal women, you are going to give the score of 3. Okay. So that should be put in that formula. So actual CA125 levels, if the CA125 is 55, 65, so that score should be written. And what are the ultrasound characteristics? That scoring should be written. And then menopausal status scoring should be written. So if you multiply this, okay, when the score is more than 250, in those women, the risk of malignancy is quite high. Okay, so those women should be referred to the oncologist for the better management.
Yes, ma'am.
Okay, so that is, there are many scores which are available. Okay, RMI is one of the simple things which is usually practiced. Okay, but there are many other ultrasound markers. There is IOTA, International Ovarian Tumor Analysis Group, ATEXA model, and all that. That is usually not asked for undergraduates and all that. So RMI is one thing which you should know usually. Okay, yeah. So this is the one. This is something which we should know before going for the surgery, so that we'll be able to make out whether it's probably a benign tumor, probably it's a malignant tumor, or you have clear-cut features of malignancy. Okay, so you have got 100% you're sure it is a benign ovarian tumor, or we are not sure what are the characteristics. It could be probably benign or probably malignant, or you have got characteristics, clear characteristics of malignant ovarian tumor. So based upon this, you are going to do a management. Okay, yeah. So coming to the treatment part.
Ma'am, an explorative laparotomy is performed and the tumor is subjected to frozen section.
Yes. So laparotomy and procedure, that is a common thing. Yes. So you have to do a laparotomy, and if you are suspecting a malignancy, like here in case you're not sure, like it's a variable consistency. Okay, you're not sure. It could be probably benign, but you're not sure. Okay. In those cases, it's going to be it's called as staging laparotomy. You're going to do a laparotomy. You're going to stage the disease. Okay. So in ovarian tumors, it is actually a surgicopathological staging. So you're going to do the surgery, see whether what are the structures which are involved, what all organs are involved. Then you are going to confirm later with the histopathology later. Okay. So that is called as staging laparotomy. So staging laparotomy is done when you're not sure of the characteristics of the mass. You're not sure whether it is benign. You're not sure whether it is malignant. In those cases, you are going to do a staging laparotomy. Okay. Yeah. You are 100% sure it is benign. Okay, like CA125 is less. All the ultrasound features, it is smooth loculated cyst, less than 10 centimeters in size, without any solid components, no thick septations, and ultrasound Doppler shows no increased vascularity. So all these go in favor of a benign tumor. In those cases, you are 100% sure it is a benign tumor. You can do only enucleation of the cyst, that is called as cystectomy. You need not remove the whole of the ovary because you know that it is a benign tumor. So you can conserve the rest of the normal ovarian tissue in that ovary.
Yes.
Okay. So you can do only ovarian cystectomy, or the enucleation of the cyst can be done.
Yes, ma'am.
Okay. But if you are not sure whether it is a benign or malignant, then you can go ahead with a staging laparotomy. But here, because she's a young girl, you can remove one side ovary and send for a frozen section. Then you can plan the rest of the surgery. So with the frozen section, as you mentioned, it is very important plan of management during the intraoperative, which will help you to decide about the what should be done with the rest of the procedure. Whether you want to go ahead and do even omentectomy, or even the para-aortic or the lymph node sampling is required or not. So all this can be done during the staging laparotomy. But because she's a younger girl, fertility preservation is of very importance. Okay. So even if it is germ cell tumor, even if it is malignant on one side, it doesn't matter, other ovary can still be conserved. Okay, because germ cell tumors are highly sensitive for chemotherapy and radiotherapy. Chemotherapy, they're highly chemosensitive. Okay, so you need not remove the other ovary. Even if you have a suspicion of malignancy in one ovary, in one of the germ cell tumor also, you need not remove the other ovary. Okay, but you are 100% sure that it is clear-cut malignancy. In that case, it is going to be a cytoreductive surgery. So you have to remove as much of tissue as possible. So whatever cells are there, malignant ovarian tumor is going to be removed. Along with that, you are going to remove the uterus and the other adnexa. Both bilateral salpingo-oophorectomy and hysterectomy will be done. And wherever the deposits are there, all of the omentum may be removed. There is a deposits on the peritoneal surface, under surface of the diaphragm, and there can be deposits on the intestine. You may have to remove, excise all those deposits has to be removed. So it is important to remove as much as possible. You have to remove all the metastatic deposits has to be removed as much as possible. That is called as optimal debulking. Okay, so in cytoreductive surgery, you remove as much of the disease as possible. Whatever macroscopic metastasis is seen, all that should be removed.
Yes, ma'am.
Yes. So you know what are the chemotherapy agents which are used for germ cell tumor?
Yes, ma'am. So there is bleomycin, ma'am. BEP, etoposide, and cisplatin or carboplatin.
Yes. Okay. So these are the important things what you should remember. Okay. And what are the general chemotherapy drugs which are used for the epithelial ovarian tumors?
Ma'am, paclitaxel and cisplatin or carboplatin.
Carboplatin drugs are the ones which are used.
Yes.
Okay. Yeah. Yes. So these are actually important. So you should know the staging, FIGO staging for the ovarian tumors, which they may ask in the exam. Okay. Yes. So any other doubts in the mass per abdomen presentation as such?
Ma'am.
Yeah.
There is a doubt, ma'am. Here, if examiners ask about counseling part of the thing, what should be mentioned? Because many times examiner ask about counseling of the patient, because 14-year-old ovarian removal may be the option. Will the fertility will persist or not? How to counsel about that?
Yes. So first thing is you have to confirm your what exactly is the type of tumor using ultrasound and the CT or MRI. Here she had mentioned the CT and MRI. I didn't go into too much details into that. So before plan for a surgery, you have your almost confirmatory diagnosis that whether there is a benign ovarian tumor or whether it's a malignant ovarian tumor. Okay. So based upon your findings, you have to counsel the girl. Okay. That surgery is definitely necessary in your case. And if it is benign ovarian tumor, you are going to do only remove the cyst. Cystectomy is going to be done, leaving the rest of the normal ovary behind. But anyway, 100% diagnosis will come only after histopathology of the tumor. So rest of this, you may plan the surgery later also. Okay. So ideally in younger girls, you have to counsel that you are going to do a conservative surgery. Okay. Then you can, based upon the histopathological diagnosis later or the frozen section diagnosis, you may plan your surgery at a later date again. Okay. And because she's a younger girl, she's not in the age of consent. She cannot give the consent. You have to counsel the parents also regarding the what exactly is the surgery which is required. Okay. And because she's in the younger age group, fertility preservation is very important. As I mentioned, even if it is malignant, even if the frozen section shows that it is malignant, you can remove only one side ovary. The other ovary you can always conserve. Okay. So importance of counseling is, one thing is not only in the younger girls, if you are removing the tumor in the other reproductive age women also, like you may have to remove both the ovaries. So you have to clear cut, you have to mention that if you are by removing because it's a malignancy, you may have to remove both the ovaries. Okay, and she may be at risk of developing cardiovascular or the osteoporosis morbidity, but she cannot be given hormone therapy if it's a malignancy. Okay, so based upon your findings, you have to counsel her. In younger girls, you have to counsel regarding the possibility of risk of malignancy. And the final diagnosis is possible only after frozen section and the histopathology. So you may have to do a conservative surgery. Other ovary is going to be preserved, but you have to follow her up later. If it's a benign ovarian tumor, she doesn't need much of a follow-up care later.
Okay, thank you, ma'am.
So counseling is mainly regarding fertility preservation and the hormone replacement therapy if required. Okay, but HRT is given only for benign conditions. If you have done surgery for benign ovarian tumor only, like for some benign conditions, you have removed both the ovaries. Okay, you may give her hormone replacement therapy, but not for a malignant condition.
Ma'am, I had a doubt, ma'am. In case a tumor, ma'am, which is this large, it undergoes some complication like torsion or hemorrhage or infection or something. Ma'am, do we then do oophorectomy of that side? Like, do we remove the ovary of that side, or only the cyst removal is enough, ma'am? Again, 14-year-old patient, ma'am. What do we do there?
So we have got new consensus guidelines, which has come up only in the last year for torsion ovarian cyst. Okay. So yes, most of the ovarian tumors are painless. Like we discussed earlier, most of the ovarian tumors usually have got vague symptoms, but they become painful when there is a torsion, infection, hemorrhage like this. Okay. When the girls present with torsion ovarian cyst, okay, the whole pedicle has undergone torsion, whole of the ovarian ligament, and sometimes the whole of the fallopian tube also would have undergone torsion. Okay. So that has led to congestion and edema. So what we do, the management in younger girls, because preservation of the ovarian tissue is of utmost important, you are going to do only detorsion and you have to fix the ovary. Later, at a later date, you can ask her to come back. So once the ovary has become normal tissue, then you have to attempt the cystectomy. You cannot do detorsion and cystectomy at single sitting because everything has become friable and edematous because of the torsion. So you try to do a cystectomy in that setting, you may have to remove the whole ovary. Okay. So whenever there is a torsion is there, all of the tissues are actually edematous and friable. So best thing is to do only detorsion. You have to completely untwist the pedicle. Ovarian pedicle has to be untwisted and it should be fixed. Okay, so there should be detorsion and fixing procedures will be done. Later, you ask them to come back for a relook laparoscopy or a relook laparotomy has to be done, followed by removal of the cyst later.
Yes, ma'am. Okay.